Hello everyone, welcome back to Comment Made Easy, and I hope you all are doing very well. Before we begin, let me remind my dear students that the contents of this channel are only to supplement your knowledge, not to replace the regular online and offline classes in your institution. So please attend your classes and do not miss them. Also, if you like our contents, please subscribe to our YouTube channel, like the videos and share these videos with your friends, with your batchmates, with your juniors. Also, if you are a teacher, then with your students. Please follow our Facebook page and the link will be given in the description. Very often we talk about the sensitivity or specificity or predictive values of different screening test or diagnostic test. So all these things come under the concept of validity, which is one of the criterion that a test must fulfill before it can be applied as a screening test or diagnostic test. So in today's discussion, we are going to talk about validity in details. In previous videos, we already discussed what validity is. Validity is basically how accurately a test identifies those people who are actually suffering from the disease and also exclude those people who are not suffering from the disease. That means they are free of the disease against the gold standard. Now, if you remember, I already said there is no test available which is 100% accurate. But there must be some test which is the best option among the available test, so that can be considered as a gold standard, and whatever rather whoever is testing positive with the gold standard test can be considered as the people actually suffering from the disease, whereas people who are testing negative with the gold standard test can be considered as the people who are actually free of the disease. And then we compare this finding with the finding of the new test or any alternative test, and then we try to find out how accurate this new or alternate test is as compared to the gold standard, and that is how we compare the validity. So whenever we talk about validity, there are certain terminologies we come across, like true positive, false positive, true negative, false negative, sensitivity, specificity, and positive predictive value, negative predictive value, etc. And we are going to discuss each and every of these terminologies in detail today. Now first, the reality check. A test may not be able to detect everyone with the disease. So that means even though in a given population, if everyone is suffering from the disease, a test may not give positive result for all the people who are suffering from the disease. Some of the people will also come as negative. So that is why no test is 100% accurate. Everyone tested positive may not actually have the disease. So this is also very important. A person having positive result from any diagnostic test or screening test may not actually have the disease, right? Similarly, if someone tests negative for a particular disease, it is not always guaranteed that he is free from the disease or he is not suffering from the disease. So as you can see, this can be somewhat confusing and also something we should be worried about. So true characteristic in the population. So in reality, what is happening, some of the people are having the disease and some of them who do not have the disease. So in these two columns, we are showing the actual or true characteristic in the population. This is the test result, right? So we are conducting this particular screening test or diagnostic test on this group of people, and some of them will be tested positive and some of them will be tested negative. So if we look at these four cells A, B, C and D, we will see that A cell represents those people who actually have the disease, but who actually have the disease and they also have tested positive for the disease, right? What about C? C is those people who actually have the disease but they have tested negative for the disease. On the other hand, B represents those people who do not have the disease but even then they have tested positive, whereas D are the people who are free of the disease, that means they do not have the disease and they have tested negative. So A and D, these cells are okay. This is what we are expecting. So if someone is having the disease, he should be testing positive. So that is cell A. Also, those who are not having the disease, those people should be testing negative. So that is cell D. The confusion lies between the cell B and cell C, right? So we have to see this population A who have the disease and tested positive, they are considered as true positive. So true positive, this positive or negative, you can see we are talking about true positive, false positive, true negative, false negative, etc. So this positive or negative is basically what the test result is. The first word true or false is basically when you are considering the actual characteristic in the population. So true positive means the people have tested positive and they're actually true. The result is actually true because they are actually suffering from the disease. So true characteristic is they have the disease and test result is positive. B is true characteristic, they do not have the disease and test result is positive. So they are positive but they are actually not suffering from the disease, so that should be false positive, because even though they are positive, this is not a true positive, they are false positive because the result is false. What about cell C? They have the disease but they have tested negative. So of course there is some kind of negative, but since they have the disease and even then they have tested negative, this is false negative, right? Also, what about D? They are not suffering from the disease and they have tested negative, and rightly so. So this is why this is known as true negative. So even from these names we can tell what is the actual characteristic and the test result of the person. So true positive means these people have tested positive and they are actually suffering from the disease. False positive means they have tested positive, but since this is false, that means they are actually not suffering from the disease. What about false negative? That means they have tested negative, but this is false. So it means they are actually suffering from the disease. And what about true negative? It means they have tested negative and they are actually free from the disease, or they are not suffering from the disease. So this is all about the true positive, false positive, true negative and false negative. So the same table I have written here, and here I have given an example for you to understand. So suppose we are talking about any disease, say hypertension or any other disease, and you can see 80 people, they have the disease and they have tested positive. So basically they are the true positive. So that is why true positive is total 80. What about 100? These 100 people, they do not have the disease but they have tested positive. So this positive is not the true positive, they are the false positive. So false positive is 100 people. This 20, they have the disease but they have tested negative. So they are negative but that is false. So this is false negative, 20 people. And these 800 people are those who do not have the disease and also have tested negative for the disease. So they are negative and they are true negative. So these are the numbers. So this is how we identify the population in context of the actual characteristic of the population. That means whether they are having the disease or not in real situation, and also the test results, which can be either positive or negative. Now that we have understand the concept of true positive, false positive, true negative and false negative, I think we can move on to the next segment, that is sensitivity and specificity. So I mentioned that not all the tests have 100% accuracy. So that means if a particular test is conducted on some people and all of them are suffering from the disease, ideally all of them should be testing positive. But in real situation, we see that some of them may even test negative even after having the disease. Similarly, if we conduct a particular test on people who are actually free of the disease, we will see that some of them will still test positive, right? So these are the false positive and false negative results. Sensitivity tells us about the ability of a test to identify correctly all those who have the disease, that is true positive. So as I mentioned, people who have the disease, based on the test result, they can be true positive, that means they will test positive, or they may test negative, which is basically the false result, and that is why they are considered as false negative. So this true positive plus false negative is basically the total number of people having the disease. Out of these people, we want this true positive number as high as possible. Higher the true positive, higher is the sensitivity of the test. Right. So if we look at the formula of the sensitivity here, it is given by true positive divided by true positive plus false negative into 100%, because sometimes we express sensitivity as percentage. Now, true positive is the number of people who have the disease and tested positive divided by true positive plus false negative, which is basically the total number of people having the disease. So, if we get more number of people testing positive out of all the people who are having the disease, that will give higher sensitivity, which is something that we always want. This is an example. Here we have to calculate the sensitivity. So as per the formula, true positive is 80 people who have the disease and tested positive divided by total number of people suffering from the disease, that is true positive plus false negative. So true positive is 80, false negative is 20, that is 100. So 80 divided by 100 into 100% is 80%, right? So how do you interpret the result? 80% sensitivity means 80% of the diseased people screened by the test will give true positive result and the remaining 20% a false negative result. So out of all the people who are suffering from the disease, 80% of them will have a positive result and they are the true positive people. On the other hand, the rest of the 20% people will give negative result and they are the false negative. So higher the sensitivity, higher is the proportion of people having the disease who will test positive. Moving on to specificity, it is the ability of a test to identify correctly all those who do not have the disease, that is true negative. Same thing, same concept here. Those people who are not suffering from the disease, we want all of them should be testing negative, but even then some of them will test positive, which is false positive. Rest of the people who do not have the disease and tested negative are the true negative, and we want this true negative to be as many as possible if we want to have higher specificity, right? So the formula of specificity is true negative divided by true negative plus false positive. True negative plus false positive is basically total number of people who do not have the disease, and same thing, it is also multiplied by 100%. The same example is given here. The specificity is here true negative, that is 800 divided by true negative 800 plus false positive, that is 100, so 900. So 800 divided by 900 into 100%, which is about 88.9%. So the specificity of this test is 88.9%. So how do we interpret this result? So interpretation says 88.9% specificity, which is basically about 89% specificity. It means that about 89% of the diseased, non-diseased people who do not have the disease will give true negative result. So they will be testing negative, and that is a true negative result because they are actually not suffering from the disease. And the remaining 11% of the non-diseased people screened by the test will wrongly be classified as diseased when they are not. So that means this 11% people, even though they do not have the disease, still they will be testing positive. And since this is a positive result and this is a wrong result, they are the false positive, right? So in spite of having no disease, they will still be classified as diseased, which is wrong. Of course, we want the specificity to be as high as possible, just like sensitivity. Now, what are the problems with sensitivity and specificity? Now, this sensitivity and specificity both are the basic parameters of any diagnostic or screening test or tool, and they're fixed parameters, and depending on the situation or different settings, the sensitivity and specificity does not change, right? We know what is sensitivity and specificity because we already discussed. Sensitivity only tells us about what proportion of the diseased people will test it positive, while specificity only tells us about what proportion of non-diseased population will test negative. Now, when we conduct any investigation on any person, right, the result comes as either positive or negative, and based on that we decide whether the treatment or any other management should be started or not. We are not concerned about what proportion of people having the disease will test positive. Rather, we want to know if a person has tested positive, whether he is actually having the disease or not, right? Similarly, if a person tests negative, whether he is actually free of the disease or not. So our interest is to know if one of our patient has tested positive on ELISA. Suppose you are testing for HIV/AIDS and he has tested positive on ELISA test. What are his chances of really having HIV infection? Or if he has tested negative, what are the chances that he really does not have the infection? Because suppose in this serious kind of infections or any other disease, where the diagnosis of the disease can change the life of a person. Suppose since here we have talked about HIV/AIDS, say a person has tested positive and we declare that the person is suffering from HIV infection. Now this is a life-changing experience. If in reality the person is not suffering from the disease and yet he tested positive, that means that is a false positive result. Imagine what will be the effect in that person's mind when we tell him that you are suffering from HIV infection, when in reality he is not suffering from the disease, right? The reverse or the opposite is also very much important and dangerous. Suppose we declare a person that you are not suffering from HIV infection based on the negative test result, and suppose that is a false negative result, that means he is actually suffering from HIV infection, and maybe the person is having regular physical interaction or intimation with his wife or any other person. The person will possibly be spreading the virus to the other persons, right? Because we already told them that you are not suffering from the disease, so that means you will not use any kind of protection or precaution probably. That is also very dangerous. So this is what we are concerned about. That means whether a positive result is actually true positive or false positive. Similarly, if a negative result is actually true negative or false negative. And all these questions cannot be answered by sensitivity or specificity of a test. For that, we need to address different parameters, which are the predictive values of the test. Predictive values reflect the diagnostic power of the test, and they depend on the sensitivity, specificity and disease prevalence, right? There can be two types of predictive value of test, that is positive predictive value, also known as predictive value of a positive test, and negative predictive value, also known as predictive value of a negative test. Starting with positive predictive value. The predictive value of a positive test indicates the probability that a patient with positive result has in fact the disease in question. So if a person turns out to have tested positive for any disease, what is the probability that he is actually having the disease? That is given by positive predictive value. The more prevalent the disease is in a given population, the more accurate will be the predictive value of a positive screening test. That means if the prevalence of a disease increases in a given population, the positive predictive value of the test also increases. Now let us go back to the same 2 into 2 table. Positive predictive value is given by this formula: true positive divided by true positive plus false positive into 100%, right? Because we express it in percentage. So what we are seeing here, in the numerator we have true positive, that means who have the disease and who have tested positive. In the denominator we have true positive plus false positive, that means all the people who have tested positive. So basically what we are trying to see is, out of all the people who have tested positive, how many of them actually have the disease. That is positive predictive value of the test. Example, so true positive in this table is 80 and false positive is 100 because they have tested positive and they do not have the disease. So 80 divided by 80 plus 100, that is 80 divided by 180 into 100% is 44.4%. Now how do we interpret this result? 44.4% positive predictive value of the test means that if someone tested positive by the diagnostic test, there is 44% chance that he is actually having the disease. So as you can see, this positive predictive value is quite low. So if a person tests positive, there is only 44 or 45% chance, not even 50% chance, that he is actually having the disease. So that is why we also want the predictive value of the positive test or positive predictive value to be as high as possible. Now coming to the negative predictive value. The predictive value of negative test indicates the probability that a person with negative test result is in fact free of the disease in question. So same thing as positive predictive value, but here we want to see that if a person tests negative, then what is the probability that he is actually free of the disease. That means he is not suffering from the disease. The less prevalent a disease is in a given population, the more accurate will be the predictive value of a negative screening test. So this is basically the opposite of positive predictive value, where if the prevalence increases, positive predictive value also increases. But in this case of negative predictive value, if the prevalence of the disease decreases, then the negative predictive value increases. Now coming to the formula of this negative predictive value. In the numerator we have true negative divided by, in the denominator we have true negative plus false negative. So as you can see, true negative are the people who do not have the disease and also have tested negative, and the denominator is true negative plus false negative, which is basically all the people who have tested negative. So basically we are saying how many of the people who have tested negative are actually free of the disease, right? This is the same example here. So negative predictive value is given by true negative divided by true negative plus false negative. True negative is 800, false negative is 20 because they have the disease. So 800 plus 20 is 820. So the negative predictive value is 800 divided by 820, which is 97.6%. So 97.6% negative predictive value of the test means that if someone tested negative by the diagnostic test, there is about 97%, or you can say 98%, somewhere between 97 and 98% chance that he actually does not have the disease, and there is only about 2 to 3% chance that he actually has the disease but still he tested negative. Of course we want the negative predictive value to be as high as possible, just like positive predictive value or even sensitivity and specificity of the test. So now we also understood what is positive and negative predictive values. They basically tells us about, out of all the people having a particular test, positive or negative, suppose you're talking about positive predictive value. So if a person tested positive, what is the probability he is having the disease? Or if he tested negative, what is the probability he is free of the disease? Sometimes positive and negative predictive values can be calculated with limited informations like sensitivity, specificity of test and prevalence data. Now let me show you something which I already showed in previous slide. Here the predictive accuracy depends upon the sensitivity and specificity of the test and the disease prevalence. So suppose we do not have the information like true positive, false negative and true negative. This data we do not have. What we have is the sensitivity and the specificity of the test that we are using, and also the prevalence of the disease in a given population. In that case also we can calculate the positive and negative predictive values. These are the formula given. So positive predictive value is given by sensitivity into prevalence divided by sensitivity into prevalence plus 1 minus specificity into 1 minus prevalence. Negative predictive value is given by specificity into 1 minus prevalence divided by 1 minus sensitivity into prevalence plus specificity into 1 minus prevalence. Now to be honest, these are a little bit advanced topic and not very important for undergraduate students, but again you can have this in your post-graduation entrance exam as MCQ. So it is always good if you go through this slide and try to remember this formula. These are otherwise not important for your exam purpose in your undergraduate level. We have to remember that while using this formula, the sensitivity or the specificity of the test and also the prevalence of the prevalence of the disease should be expressed in number, not in percentage. So suppose if the sensitivity or the specificity of the test is 80%, we should write 0.8. If the prevalence of the disease is say 30%, then you should write 0.3. We should not put the percentages directly into the formula. If we do that, we shall get erroneous and very impossible kind of values for the positive and negative predictive values, and those will be inaccurate. So always remember to use this formula. We have to use the numbers for sensitivity, specificity and prevalence. What about the relation between prevalence of disease and predictive value of a test? This is something that we already discussed in previous slides. When the prevalence is high, positive predictive value increases. Positive predictive value decreases as the prevalence goes down. This is reverse in case of negative predictive value, which is high when the prevalence is low, but it goes down while the prevalence is high. So I think this may be a little bit confusing. I shall discuss and explain this thing with a very nice example, but that will take a little bit of time, and that is why we shall discuss this particular slide in the next video. With this, we conclude today's session on validity. If you like the video, please subscribe to our channel and share this video with your batchmates, juniors, and also with your friends from other colleges. We also have our Facebook page. The link is given in the description, and you can also follow our Facebook page. Take care, and we shall see you in our next video.